volumes to get into those lungs. So I'm going to show you what a PEEP of 5 looks like. And the difference that makes. Just that little bit. So that's how much that we need in order for our bodies, our lungs to help our lungs. Any questions on that? And this will give you also an idea, because I'm going to have to get some new lungs next year, but we have little bitty blebs here that are starting to work. That would be a potential pneumo at some point.
I'm going to get closer to you.
Show you that. So, little bud there. So as respiratory, one of the things that we're monitoring when we're going in, we're constantly looking at our patients. When we walk in, we're not just going to a machine, writing numbers down and just walking out. We're looking at our patients. We're checking to make sure our ET tubes haven't been moved, because nurses have to go in, they have to roll their patients, do all the things they do, and sometimes those things the tubes can get a little moved out and in or out a little bit. So we're constantly checking the measurement of our tubes. We're moving them side to side to try to prevent breakdown in the mouth. And then we're always monitoring these numbers over here really closely, because this right here is going to tell us if we have any kind of a change in our patient's status by looking at all these numbers and charting them. So right now, my peak airway pressures on this patient are ideal. We're at 20. Everything's looking good with my patient. We're on a good road here. I come back in a few hours, and lo and behold, my peak airway pressures jumped up to 50. Something has changed. I've had an acute change in my patient, and I need to figure out what it is. Either I have a mucus plug in the tube or in the airway. I tried to suction my patient. That didn't help. Maybe my patient's gone into full-blown ARDS. Their lungs are super stiff and they're not wanting to expand. We need to figure out what's going on with our patient. So it's real important that we come over here and we monitor these numbers and watch them real close. Our PEEP, one of the things that we have to be careful with, if you guys have a patient who has really low blood pressure, you guys are doing everything you can to try to get this patient's blood pressure elevated. I don't want to have that PEEP cranked up too high or turned up too high, because that can interfere with your guys' blood pressure as well. So there's all kinds of different scenarios that we have to really be watching when we have a patient on one of these machines. So that's your ventilator. I'm going to talk about the BiPAP again and some of the safety measures that we take with those. And I'm going to show you some things. I'm going to hook this patient up on BiPAP. So one of the things, as I've been teaching this class, people tend to giggle. Okay, I gotcha. So in order for a patient to be on BiPAP, your patient has to be able to spontaneously breathe. If they're not spontaneously breathing on their own, then they obviously have to be on a ventilator. Clearly, this patient is not spontaneously breathing, but we're going to pretend that they are. If you ever have to, if you, RT is, we run with two RTs on the floor day and night. Sometimes we get spread a little thin. And you walk into a patient's room and you call me, Kathy, I need to get this patient back on BiPAP, they're really struggling, and say I'm an ED and I'm in a code. I might say, hey, go ahead and put them on it, I'm on my way. I'm getting there as quickly as I can. So if you put this patient on the BiPAP and in your head, you're like, oh man, I just stuck him on it and I forgot to hit the start button. One of the safety features that this machine has is it will detect that it's hooked up to a patient and kick on. Now keep this in mind though, a machine is a machine is a machine. You never just automatically assume that it kicked on properly and you turn around and you walk out and just leave your patient. Make sure it's running okay, and if you have the time, just stay with your patient until we can get there and we can make sure everything's looking okay. So I'm going to put this patient on. I have this patient on a pressure of 20/6. So you're going to see if this patient were truly spontaneously breathing, they were going to initiate their breath, and then this patient, especially if they're labored, this machine's going to push that air into their lungs to help them overcome whatever it is that's got them so labored. And they're not going to have to work so hard to get that air in and not get so tired. Truly, if this patient were spontaneously breathing, their lungs would be expanding a little bit more with this pressure, but it's not going to happen right now because I'm not setting a specific tidal volume. I just have that pressure. The patient's the one that's got to achieve that tidal volume. Okay. So if you notice though, again, I have those lungs are staying splinted open just enough to help with any oxygenation issues that we might be having on top of it. We do set a specific FiO2 also with these. And then we set a backup rate. So what that backup rate is if a patient happens to have an apneic moment, the machine's gonna detect that, and it's gonna push that breath. It's gonna remind that brain, oh, you're supposed to be breathing, and kick in the pressure, and then the patient will initiate the breath after that. It's just kind of a reminder for them, okay? So a patient has to spontaneously be breathing. A patient cannot be restrained when they're on a BiPAP. They have to freely be able to pull that mask off themselves. If they're gonna get sick, or if they start to panic, or whatever it may be, they have to be able to take that mask off themselves. If they're unable to take the mask off themselves, then they have to have somebody one-on-one with them, okay? If they're up on the floor and, because for the most part, we try to put all our BiPAPs in the ICU. Sometimes that's not always feasible. If they happen to be up on the floor, then they have to have their doors open at all times. Sometimes you might have a patient down in 2114 that's on a BiPAP, and they're on 70% FiO2, and say somebody shuts that door, and you're giving meds in a patient down on 2122, and that patient panics and pulls their mask off, and you don't, because the door's shut, you don't hear the alarm going off on that machine, and then next thing you know, we have a rapid response or a code blue. So we always make sure that we have the doors remain open at all times when they're on a BiPAP. In the perfect world, we have them as close to the nurse's station as possible, but that too is always not feasible. So we do the best we can in that area. We always have them on a continuous pulse ox, whether it be our continuous pulse ox or the MedTele continuous pulse ox. If you have to give your patient meds, always give yourself plenty of time, especially if you have to give them a lot of oral meds, and this patient tends to desat or they're pretty labored. So make sure you're giving yourself plenty of time to go in there. And you're going to take the mask and you're going to, don't undo the Velcro, always undo it by the clips. Undo the clips, you're going to lift the mask completely away from the face. Don't just lift it up a little bit. Lift it up completely away from the face, give the patient the med, give them their drink, make sure their mouth is completely clear, then put the mask back down and give your patient a chance to recover before you just give them the next one, okay? But it's real imperative and real important that you lift that mask completely away so you don't push anything down into their lungs. If you have a patient that's intermittently wearing it throughout the day and you call me and say, hey Kathy, my patient just finished breakfast or lunch and they need to go back on their BiPAP, I might say let's try to give it 30 minutes to an hour if we can, because even though we're pushing most of that air into their lungs, we're gonna push some of it into their bellies, and if they have a full tummy and we're pushing air on top of that, we don't want them to throw up in the mask. So we try to give them about 30 minutes to an hour to let that settle before we put the mask back on. We also try really hard to educate family members. So it's not easy to come in and see your mom or your loved one on one of these masks. They're gonna complain that they're really dry, they really wanna drink. If they're really struggling, if they're in a bad situation, the last thing we need to be doing is worrying about giving drinks, but that loved one doesn't understand that. And I have walk into rooms and I've had loved ones have that mask pulled out and a straw shoved up underneath. So we really try hard to educate family members and loved ones that we don't let them mess with the mask and the machines. If anything, if they have any concerns, just to find one of us and we'll be happy to help them with that. And just educate them that it may just not be a good time for them to have drinks. Any questions for me? All right, that's all I got. I wanted to show you, this is also just kind of an idea of what a smoker's lung looks like. It's really, I can't put it on the machines because it's super stiff, rubbery, it's got hard nodules. I do have some pneumos. I have a couple of holes here, so it doesn't get good volume, so it won't expand or do the things that it needs to do on a machine. But I also like to let people know, even though we say this is a good example of a smoker's lung, not everybody that comes in here that has chronic lung issues have been smokers their whole lives or ever in their lives. We live in a blue-collar community. We have a lot of farmers that have grew up their entire lives working in the grain fields or cutting hay or around all this dust, or we have factory workers. Just a lot of situations that can cause lung issues. So keep that in mind. And then some people just have the bad luck of the draw. They just have lung disease, and there's no rhyme or reason to it. So, but this right here is a prime example of why what kids in schools need to see right now when they're vaping.
That's what I was gonna ask if the vape pens.
Yes. I don't know, so the vaping it hasn't been around long enough for us to really start seeing those effects. Now, I will say, we've had people come into the ED that they're coughing up, young college kids, and they have hemoptysis, they're coughing up blood, and we're like, are you a vapor? Well, yeah. I'm like, we don't have those studies yet, but I think that you give us another 10, 15, 20 years and we're gonna start seeing the results of that. That's all I got. All right, somebody can turn the camera off because I don't like it.